Hello, my name is Andrew Iwa, and I am board chair for the Glaucoma Research Foundation and the executive director of the Glaucoma Center of San Francisco. It is my distinct privilege to welcome you to the annual Weston Family Lecture. This annual gathering highlights the extraordinary contributions of distinguished clinicians and scientists whose groundbreaking work enhances our understanding of glaucoma. Glaucoma affects around 3 million Americans and nearly 80 million people worldwide, making it the leading cause of irreversible blindness. The Glaucoma Research Foundation's mission is to cure glaucoma and restore vision through innovative research. This vital work is only possible thanks to the generous philanthropic support we receive, and for that, we are deeply grateful. Your contributions make a meaningful impact and bring us closer to a future free of glaucoma. Today's event was made possible by the incredible support of the Weston family. Their generosity has allowed us to host this lecture for many years. The event provides a unique opportunity to showcase important advancements in glaucoma research and to honor the enduring friendship with the Weston family. The lecture was established by Gladys and George Weston in memory of their beloved son, Danny, who sadly passed away from a brain tumor in 1998 at a young age. While we cherish the memory of George and Gladys Weston, their daughter Jane is committed to continuing this lecture in honor of her parents and to uphold her family's passionate dedication to the Glaucoma Research Foundation's vision. We are profoundly thankful for the Weston's commitment and our shared vision of a world free from glaucoma. It is now my honor to introduce Dr. Jane Weston, who will share a few words with us today.
Thank you for your kind introduction, Dr. Iwa. It's my great pleasure to welcome you all to the 2024 Weston Family Lectureship, an event that holds deep personal significance for me. The lectureship was established in 2007 by my parents, George and Gladys Weston, in honor of their dedication to advancing glaucoma research. My father, George, suffered from low-tension glaucoma. He was fortunate to be under the care of Dr. Andrew Iwa, who successfully preserved his vision throughout his life. Dr. Iwa's passion for glaucoma research was evident to my parents, and in appreciation of the care my father received, they created this lectureship to provide the public with insights into cutting-edge glaucoma research. Originally, this lecture was founded in memory of my brother, but it is now quite fitting that it honors my parents as well. Reflecting on past years, especially those before the COVID-19 pandemic, I have fond memories of my mother welcoming guests with her signature warmth and grace. She and my father took great pride in hosting this event, always eager to invite their friends and colleagues to learn about the latest advances in glaucoma research. With today's virtual reach, I know they would have been thrilled to see how this lectureship is now shared with people all around the world. Each year, the Glaucoma Research Foundation selects a speaker for this lectureship who has dedicated his or her career to advancing our understanding and influencing the treatment of this disease. Today's speaker, Dr. David Friedman, who will soon be introduced to you, is no exception. I hope you find today's lecture both enlightening and inspiring. I have no doubt that I will.
Thank you, Jane, for your continued friendship and our shared vision of a world free from glaucoma. My name is Tom Bruner, and I'm President and CEO of Glaucoma Research Foundation. Our partnership with the Weston family began almost 20 years ago, and we are profoundly grateful for their collaboration and exceptional support over the years. We cherish the memory of George and Gladys, and we're deeply touched by Jane's commitment to honoring her parents and her brother Danny through the annual Weston Family Lecture. This tradition truly embodies the lasting impact of their family's legacy. It is my privilege to introduce our good friend and the Weston family lecturer, Dr. David Friedman. Dr. Friedman is professor of ophthalmology and co-director of the Glaucoma Center of Excellence at Harvard Medical School. He is also the director of glaucoma services at Mass Eye and Ear. And Dr. Friedman received his medical degree at Harvard Medical School and his PhD and master's in public health at Johns Hopkins University. He completed his ophthalmology residency at Wills Eye Hospital in Philadelphia and received his glaucoma fellowship training at Johns Hopkins Hospital. Our friendship with Dr. Friedman began in 2005 when he received a Schaefer grant. Since then, he has become a world-renowned leader in clinical care, research, and education. We are so fortunate to have him on our Schaefer Grant Scientific Advisory Committee since 2019, our research committee since 2022, and since May of this year as a member of our board of directors. It is my great honor to welcome Dr. David Friedman.
It's a pleasure to be here today. I know this audience has many people who have a stake in how we're going to take care of glaucoma in the future, and I hope to be able to enlighten you as to where I think we're going and what directions our care processes will take. The big challenge we face is demographic. The world is rapidly aging, and there are not enough working age individuals to care for people the way we're doing it now. And we have to come up with better solutions. This gives the global population pyramid, and what you see here is largely a very large base and very few older people. But by 2070, the base starts flattening out, and there's just a big pile of elderly people on top. In the US, it's not nearly as bad. This shows 2025 on your left and 2050 on the right. But what's hidden in there is that the over 65 population will increase from about 18% today to close to 22% in 2050. I found this a really remarkable study. It was just published very recently. And what we see on this left is the gray bar is showing the total supply of ophthalmologists, and it's around 21,000. And the total demand is the red bar today, which we're just barely meeting demand. And if we increased access and allowed everybody who needed care to get it, we'd be a little below demand. And over the next 15 years, this situation is going to really become somewhat dire. The number of ophthalmologists will be around 18,000 because we are, in fact, an aging group, and we have not been creating enough new ophthalmologists to replace ourselves. And then the number of people who will require our care, because we are an aging population, is going to increase. And if we really get everybody into care, it's going to increase even further. So we are going to be way below meeting the demands in ophthalmology, and glaucoma is a very common illness and requires many visits, and so that will be particularly challenging. Fortunately, at the moment, we are not being as efficient as we can be, and I think one of the major changes will be in increasing efficiency of how we care for people, but that's going to mean that the care process will change. This shows an optic nerve of a patient with glaucoma. The inferior rim of the nerve is damaged, and this is in 2001, and the patient was treated and monitored. And this shows that we saw them over many years, and they were completely stable by visual field testing until about 6 years later when there was a confirmed worsening, and at that point a change was made. Well, if you think about this process, it involved a lot of wasted time. Patient probably was seen every 4 to 6 months. Pressures were tested, they were stable, testing was stable, and only at 5 years did we determine that they were getting worse and then make a change. So how much of that coming in, checking them, talking about their families and their activities was useful in terms of patient care? I would say not a lot of it. We also are under-testing our patients. If you look at one test per year, let's say, and that's what a lot of practices are doing, the time needed to detect a fast progressor, meaning somebody who's getting worse at a decibel per year, severe glaucoma could be considered greater than 16 decibels. So this is a person who could go from normal to severe in 16 years. Over 5 years, we can detect change with one test per year at that rate. It would take us 5 years. And if we doubled the number of tests, it would take us 3.5 years. So our current approach of testing is way inadequate to identify people who are getting worse in a timely fashion. I show these two visual fields because if you see them, you'd probably say they look the same. This is 6 months apart. They don't look any different. But this patient was enrolled in a research study that I collaborated in with Dr. Felipe Medeiros, who initiated the work. And you can see here, we did a cluster of 5 visual fields all within a month. And then a month later, we did another 5 fields. And what's quite obvious, if you look at the 5 later fields, is on average, this patient was doing worse. We selected in that previous slide the ones that are circled in red, but overall, this patient was getting worse fairly quickly, and that was detectable at just 6 months. And this shows at the last follow-up several years later that indeed there was a fair amount of loss. And we actually intervened on this patient. So they were getting worse very rapidly, and then the worsening decreased because of the intervention, but still there was ongoing worsening. So this is before any intervention in that 6-month period, and then later the rate decreased because of further intervention. Clustered testing like this can actually detect rapid progressors in 6 months. 15% of this study population was getting worse at 1 decibel a year or more, and 18 of those 19 detected to be progressing were rapid progressors. So I think in the future, this concept will actually be adopted by the doctors caring for glaucoma patients, and we will be doing much more frequent testing, and we'll have to move outside the office to do this. I want to now reflect a little bit on identifying individuals with glaucoma, and I think AI is going to really change what we do, and AI is artificial intelligence. We currently have low-cost cameras, and we're able to image the eye fairly inexpensively. This shows one of the cheaper models. This is a handheld version, and we can use those images to identify glaucoma in the community. And then we also can use highly sensitive, more expensive images to perhaps confirm those findings in centralized testing locations. And we can centralize testing anywhere or screen anywhere. You could imagine a camera is relatively small. It could easily fit in a Target or in the Department of Motor Vehicles, or even at a McDonald's if they were interested. We already have photo screening for diabetic retinopathy, and it involves AI. This shows what deep learning can do with diabetic retinopathy, and this graph on your left shows very good performance of a screening device. Sensitivity is the ability to identify somebody with disease. So in this instance, over 97% of individuals who have diabetic retinopathy are picked up by the camera using an automated machine algorithm, so no human involved. And specificity tells you the likelihood that you will test negative if you are normal, so that the test won't inaccurately say that you have disease. And this is 93%, which is quite good. In screening populations, you really don't want to overcall a lot of disease, because then you'd be referring too many people in for care. And with this alternate approach, you can detect 90% of people and only overcall people who are normal 2% of the time. So this has now been FDA approved, which was the first autonomous system that can now diagnose an eye disease or any human disease on its own. And these are being implemented in clinics to help identify diabetic eye disease. Artificial intelligence is here to stay. This shows similar studies looking at the optic nerve with similar algorithms and pretty good performance. Not as good as with diabetic retinopathy, but not terrible. And the problem is obvious here, that nerves can vary a lot. On the left, you see what looks like a relatively glaucomatous nerve, but in the middle, you have a giant nerve, and you get all kinds of nerves. So The ability of machines to separate all of these out may be limited, but for the most part, it can be somewhat effective, certainly as a first pass. This just shows a currently implemented automated system in Australia, and people can go in and get screened for glaucoma, diabetic eye disease, or macular degeneration with these machines. And you can see here, you get a report that says there's glaucoma, there's no diabetic retinopathy and no macular degeneration, and you can walk away after a few minutes knowing that, just having sat in front of a camera. There's also really creative ways to look for glaucoma. This shows serial images of the optic nerve. This is a beautiful study showing that if you took the pictures over time, look at the plot A, you see all those photos, they look kind of the same, but you can use AI to translate those photos into nerve fiber thickness, and the map shows clearly that there is a decline in nerve fiber layer thickness over time, whereas in D, the patient is stable. And so we could even use photos that are taken routinely for some screening purpose and then integrate all the data over time and identify people who have glaucoma as well. It's all well and good to identify people with glaucoma, but in almost every study done in the United States, nearly half of those who screen positive never attend an eye exam. So you can't just screen, you have to figure out ways to get people into care, and that's really a whole set of processes that will be needed to facilitate entry into care. We currently have funding from the Centers for Disease Control to use AI to detect people for glaucoma who are already being screened for diabetic eye disease. So what I was saying before, how care will change, I'm hoping that this kind of research will lead to improved detection and better access for people who are at high risk for glaucoma. I also think that all of this points to remote care, less care in the office, and that's for two reasons. One is we could test a lot more outside the office. We would give greater access to those who have difficulty accessing care in the office. And we could test more frequently and reduce the burden on the healthcare system. And as I showed you, we do not have enough ophthalmologists to care for everyone who needs it. What do we need to monitor patients? We need to know their vision, their eye pressure. We need some functional test of their side vision. And we really do want to get serial consecutive measures of the optic nerve, and that would involve most likely optical coherence tomography or OCT. Other data that we need occasionally might be to know if the angle is still open, whether a patient has open angle or angle closure glaucoma. We'd like to know the slit lamp findings. Certainly we could miss things if we don't look at the eye every now and again. And we want to know what the back of the eye looks like, because we're not just worried about glaucoma, we're worried about other eye diseases as well. But almost all of this could be done in a remote fashion. This shows a review done in 2019 looking at all the different visual acuity testing applications out there. And this was what they looked at. And you can see there are several that were reliable and validated that could be done on a computer screen or a tablet. And so a patient could test his or her own vision at home. People can now measure their pressure at home. This is the home tonometer called the iCare Home, and it can give you measurements that a patient can take for him or herself. There are virtual reality and tablet methods for measuring the visual field, and I believe that over time these will be ubiquitous and we will be getting far more visual field tests using these kinds of devices. There's also automated ways to look at the angle. There's a very expensive, high-quality imaging device of the angle that can capture very well whether an angle is open or closed. And you can see here the heat maps show that it really is looking at the angle, and this is all using artificial intelligence. So how do you get these expensive tests like the one I just showed you, or the OCT? Well, we already have examples back in the early days when blood pressure cuffs were expensive, where you could put a quarter in and get your blood pressure done at the supermarket. And you could do similar things. This is a puff kind of eye pressure measurement. People who don't want to buy the home tonometer could pay, what it needs and get pressures. Or we could set up centers just like this, where you come in and get all of these tests, and it could be very high throughput and very efficient and lower the cost of testing for everyone. This is being done in the United Kingdom. We also need to know who is getting worse. As I said at the outset, we're not great at that. It often takes 5 to 10 years for us monitoring a patient who is getting worse to know they're getting worse. And we want to be able to pull all the data together and figure out who's getting worse sooner. And this just shows one of the early studies looking at trying to do that with artificial intelligence. And it does a pretty good job compared to the methods we currently use for detecting worsening. Another major shift that I anticipate coming is the personalization of care. What is precision medicine? Well, it's an approach to try to incorporate genes, environment, lifestyle, and other components into risk determination for patients. And then you can tailor the disease treatment to an individual. Right now, we often do the same thing for most patients. We often test patients every 4 to 6 months. We have specific treatment algorithms. We don't really pick a drug differently based on the likelihood of responding to a certain drug for a given patient. So we have a one-size-fits-all, which is a traditional approach. You have people who are variable in many ways, and they all get the same pill. And as you can see in the bottom row, some get a benefit, some don't, and some might just have side effects. Ultimately, what we'd like to move to is a much more precise approach where people get categorized according to their genes, environment, and ability to respond, and they all get a benefit, and we reduce the side effects of the things we do to people. This just gives an example here. This is the complement factor H gene. So it's a gene that we all have, and with genes, we all have 2 alleles. Some people have 2 Cs, the CC genotype. Some have 2 Ts, and some have 1 T and 1 C. And what you see on the right in the graphic is those with TT and TC have improvements in vision with treatment, whereas those with the CC genotype actually continued to get worse with the treatment. So treatment response was very different depending on your genes. And yet today, we don't apply that information to choosing a treatment, but I'm certain we will be doing that. We also know that prognosis greatly varies depending on the genes that one has. If we look at uveal melanoma, which is a tumor inside the eye, and survival, this shows your survival graph. So the blue is complete survival, and that's somebody who has no mutations. They have almost no risk of metastases and are very likely not to die from this disease. If you have the E1F1AX mutation, you also have a very low risk. Some people die, but very few. But if you have the bottom one, the BAP1 mutation, you're likely to die almost 100% of the time. So once we know these things, I believe we will have the ability to say, oh, your glaucoma is really not going to lead to very severe disease because you have these 5 genes and are very unlikely to get worse. Whereas another patient sitting in my chair with exactly the same findings, I might be much more aggressive with because they have the genes that put them at extremely high risk of blindness. This was a prediction model that was, written up in the early days, and you don't need to look at the numbers. It has like age, central corneal thickness, what the highest eye pressure was. And you can see in these kind of models, you can predict to some degree who's going to get worse. But what happens if we can add in genetic factors or even unknown factors in the fundus photos or in the OCT or in the fields that AI can pull out for us and help us do better at predicting? And that's where I think the care process is headed. Here's a really good example, and we have funding at Harvard to study this as well. These are genetic risks that have been determined for individual patients. And those with the most genes related to glaucoma, shown on the right, have a 15-fold higher chance of having glaucoma than those in the lowest risk group. And then you can look at this many different ways. People with this high genetic risk are diagnosed at a much younger age with glaucoma. Once they get glaucoma, their nerve fiber is likely to worsen more rapidly. And once they have glaucoma, they're more likely to need a trabeculectomy. Your genes drive a lot of the process. And so once we start integrating our knowledge about glaucoma genetics into day-to-day care, we will have a different approach to each of our patients. I also feel that it's been ever expanding our ability to image the eye and see more detail, and that's only going to improve in the coming years. This is just one example of an ultra-high resolution imaging of the anterior segment, and you can see Schlemm's canal and scleral spur in great detail in ways that we could not see previously, and that's only going to increase for other parts of the eye as well. So what I believe is that most patients will be followed remotely. They'll likely be identified, as opposed to in a doctor's office, by a photo somewhere where they walk across a camera and it tells them, you have glaucoma or a very high risk of glaucoma, you need to be checked. And there'll be some sort of detailed initial evaluation in the clinic. It'll involve all the various tests we currently do. And I don't know where we'll be with genetic information at that point, but maybe the patient will have his or her own genetic information. We could look at that and add that to the evaluation. And then they'll monitor themselves either at home or at kiosks or at large testing centers. And we'll collect a lot more data so that we can have a better sense of how rapidly the disease is progressing. And that will lead to very few visits, because the times that you'll need to come in will be when you're getting worse. And initially, if you look like you're getting worse, we may just have a video conversation and change the management a little and see if it stabilizes. And for the physicians, we'll have to do less, but it'll be much more focused. We'll be looking for moments where the machines, where the algorithms are failing. We'll try to integrate the findings, and really we'll try to know the best way to counsel and approach care. So what's missing for this kind of a model to occur tomorrow? Because we have most of the inputs. I think we need better mechanisms that will ensure that even if we screen, that patients can access care, because right now that's very difficult to do. We're going to need distributed testing systems, and that requires a capital investment. It's just like I showed with the Tesla charging station. All that investment to put those in place had to be there for electric cars to become popular. For this remote management system to work, we're going to need capital investment to allow patients to be seen outside of clinics. We also need a cost structure. If you think about glucose monitoring for a diabetic patient, they can do all that at home, and it doesn't cost too much. It's not, bankrupting. But right now, we don't have a way to send somebody home with a virtual reality headset and have them take tests and send them back to us on some low fixed cost structure, or to pay for it with insurance. So all of that has to be worked out. And then ultimately, there'll need to be, big data centers that can integrate all of a patient's information. So if we're getting one device at home, another device from another location, we're going to want all of that to be merged so that we can use it to inform ourselves. There's already self-guided testing stations. This one on the left is in place in Australia. You can sit down and get your screening. GlobeCheck also does similar things. So you can imagine these kind of kiosks. So I don't think we're too far from this approach. I'm now going to move on to just briefly cover how I think care will change. I think I'm going to not focus on eye pressure, because all of what we're doing today is probably going to continue and be refined to some degree. I don't see some giant breakthrough in eye pressure lowering at the moment. But for neuroprotection, I really think we're getting close, and we may also have neuroregeneration over time. This is an example of why we need this. This is a patient in our practice, 83-year-old. Eye pressures have been consistently in the 5, 6, 7 range, never over 10. And here you see this rapid worsening going on from 2015 to 2019. We need something other than pressure lowering for patients like these. There are promising targets for neuroprotection. I'm just going to show one or two. Galectin-3 is a protein involved in inflammation and cell-to-cell adhesion. And if an animal, this is an animal model, if an animal has a high eye pressure, they lose most of the ganglion cells in the retina. But if they have no galectin-3 and a high eye pressure, most of the cells are preserved. So galectin-3 is playing a role in the pathogenesis here. And this is just an example. If you injected in this model into the intravitreal cavity a galectin-3 inhibitor, this shows with the high eye pressure, and this is with the inhibitor. So we already have evidence, and this is one of many types of medications like this that could potentially protect the nerve outside of pressure. We also have some clinical trials that have been initiated. This is ciliary neurotrophic factor, an implant. And this is a factor that promotes neuronal survival and axon growth. And there was an implant that was designed many years ago now and placed into humans. And in a phase 1 study, not many patients, but there was a hint in the 5 of 11 patients who completed the fields of some potential benefit. So in a phase 2 trial, there was some evidence that the nerve fiber layer thickened. Again, not ready for prime time, but it shows that nerve growth factors can be delivered into the vitreous in a unique fashion. And I feel fairly certain that something like this is coming down the road. Many of you have heard of nicotinamide being used as a neuroprotectant. And there is some really interesting animal data, both in mouse and in primates, showing that nicotinamide can help preserve retinal nerve fiber layer and maybe give some increase in function. And there are ongoing, pretty large randomized multi-center clinical trials. In this one, they're planning to enroll 1,800 individuals, all major glaucoma subtypes. And the main outcome measure will be visual field changes over 2 years. There's also one company looking at trying to regenerate nerve cells. There's a gene therapy. There are some factors that can cause cells to become young again, to become almost like stem cells. And those factors, if properly put together, can help to regenerate nerve fibers. Life Biosciences, which is a company here, has published data showing visual recovery in a mouse model. They have preservation of function in non-human primate models, and they do on their website plan to use this in humans to assess cases of non-ischemic anterior optic neuropathy. So I'm optimistic. I think that we're going to figure out better ways to monitor our patients, and that'll allow us to care for the very large number of patients that are going to be entering into glaucoma care. The future is bright. More patients will be detected and they'll be aware of it. We'll have better information and decision-making, and more will be in care, and we will improve. We will be more personalized. We'll have novel therapies, better information. And what we'll be doing as doctors will be more engaging because we'll be directly interacting with those patients who really need our time and attention. We're moving into a new era of care, and this is the Wright brothers' early plane flight. Thank you very much. We're happy now to move to the Q&A session.
Well, thank you, David. Really a fascinating presentation on what the future of glaucoma care will look like. We do have a lot of questions. I'm curious, just from a time frame, how soon you think, and I'm aware that Harvard is doing some work with what I think it's called a polygenic risk score. So exactly what you were talking about, how many genes does a particular person have related to their glaucoma? And I'm under the impression you're doing pretty widespread full genome sequencing of glaucoma patients so that you can actually calculate that score that you were talking about and say, well, you've got 5 of those risk genes, but on the other hand, another patient might have 100 of them. So who is at higher risk and who may progress more? How widely is that used, the polygenic risk score today?
It's not really used in clinical practice, so we are doing it as part of an NIH-funded research study. There is a group in Australia trying to create a company that will offer this test to patients. This is one of those situations where you want to be sure to be thoughtful about implementing a novel test because you don't want to come to the wrong conclusions. We at Harvard are planning to also develop a similar kind of test that would be initially just we do it on a large number of patients so that we could then learn, is it really working properly? But I think it's coming. I mean, it's very around the corner. It's in the next couple of years. And anybody today, 23andMe does provide, I'm not sure they use exactly this, but they provide some level of glaucoma risk in those kinds of tests, although who knows what's going to happen at 23andMe now. But
well, it's encouraging, though, I think, that
absolutely.
we know that there's a large inherited aspect to glaucoma. And, I think if you have a mycilin gene, you're almost guaranteed to get glaucoma. But
absolutely. And what we found in some of our work here is even if you have that gene like as an allele and not as the whole, not the whole thing, not both of them, that also puts you at a very substantial increased risk in a population. And so it might be worth all of us knowing if we have those.
Yeah. So, of course, the big question I think on everybody's mind is some of these looking at changes not in how glaucoma patients are taken care of, but really on what the therapies that are optioned. And you talked about neuroprotection and even neuroregeneration. So the question I think on everyone's mind is how soon? And you did say that neuroprotection there, you mentioned the CNTF test that was done that showed some apparent positive results. When do you think you're going to be able to routinely offer a neuroprotective therapy to your patients?
I think it's a ways off. I think unless the nicotinamide story works out, which we could offer tomorrow, I mean, anybody can buy that. But in terms of a pharma, driven novel therapy, it's a process that is really difficult. Carrying out a clinical trial for neuroprotection requires demonstration of preservation of visual fields. Enrolling patients is expensive. And even if you have the best looking approach, you never know what's going to happen in a clinical trial. And so, it's going to take some real investments. I do think, that organizations like GRF could facilitate that by de-risking some things, getting some of the early studies done. But I don't think this, the FDA approval process is slow. Nothing's close to FDA approval. So I would say it's not coming for the next, 5 years, probably.
Well, but 5 years is a lot better than 25. So, and you're right. It's today it is a fairly expensive and time-intensive process to get a drug cleared by the FDA, and for good reason, because it has to really, number one, it has to be absolutely safe. And then secondly, you really want to know it's effective. You don't want to subject somebody to a drug that may really have no benefit.
Well, that's why I really think that remote testing and multiple testing could really alter that landscape and should be part of the thinking around how do we get these drugs approved. If you have a really strong ability, a really good way to detect change, we could test a lot more drugs because we could do it quickly and get the answer quickly. I did want to mention, in the past, I have just consulted like very briefly to Life Biosciences. I picked that up as an example, not to market the company or anything like that.
Okay. Well, the other big question is, some people, and you showed a visual field of someone who despite all the best efforts of lowering pressure, still lost a lot of vision. And we know there are people blind from glaucoma that have virtually no vision. And the other big question is about actually putting new ganglion cells in. And you talked briefly about restoring vision. And I'm just wondering what your thinking there is. Do you think that's ever going to happen? I mean, it's certainly more than 5 years away, but is that something in our lifetime that we'll be able to replace those lost nerve cells and people might get some level of vision back?
Yes, Matt, you're in my lifetime there, Tom.
Okay, now I am not sure I'm gonna I'd like
think
it in my lifetime. But
I think that there really are major breakthroughs happening in the stem cell area, particularly in how to integrate the axons and how to get them through layers that are usually barriers to growth. But I do worry that it's going to take a long time to get them to map back exactly where they belong and to make sure that those synapses work for patients. So I think we're more in the 10 to 20-year timeline for that to be in humans, but I don't think we're in the 50 to 100-year or never timeline. It may not lead to perfect vision, but it certainly could be expanded vision.
well, I mean, it is an exciting time, as you say, and what is being done with stem cells. It does bring up something that I think it's always important to talk about, and that is that sometimes the use of stem cells is kind of misrepresented. And I just wonder if you could comment about perhaps, should patients today be investigating some kind of stem cell therapy that they might find on the web or whatever?
Yeah, I mean, it is extremely worrisome that there are places that people can fly to and get quote unquote stem cell therapy. And there's really no evidence to support that at this point. And in fact, it almost certainly would be harmful. We have, immune responses to things. If things aren't handled the right way, you certainly could suffer an injury from that kind of effort.
So it's important to be careful and to know that there's no approved stem cell therapies, which I'm aware of today.
No.
So what you did mention that IOP is really the only treatment that we have today, lowering eye pressure. And then you did refer briefly to vitamin B, and so I'm just wondering, are there some strategies where there's diet, exercise? Are there other things that a patient can do besides just concentrating on making sure they see their doctor and take their eye drops and so forth to control their pressures? What recommendations do you give your patients on other approaches to trying to help or control their glaucoma?
I always worry a little bit about giving too much in the way of recommendations because the evidence base supporting most behavioral changes is quite limited. I think that almost every health metric is improved by a healthy diet and by exercise. So I do recommend that for my patients. I think it's a good idea. There are, things you certainly don't want to do, like hang upside down in an inversion, table or something like that. But for the most part, patients have very little control over this natural history, and it's difficult. It's difficult to give guidance about what you should do differently. I would say, one of the things I do worry about for glaucoma patients is mobility, and mobility does decline with field loss. The more field loss you have, the less you are able to do all things that make you mobile. So maintaining core body strength, maintaining your quadriceps strength so that you can handle any imbalance. And then once you know you have any limitation, being even more cautious around falls makes a lot of sense to me. So, I think that whole idea of figuring out how to adapt your life to your vision is also a very important part of being a glaucoma patient.
Well, and I know just from personal experience with a friend who had glaucoma that contrast sensitivity, which is difficult to measure, can also be lost in glaucoma and can cause people to maybe not see a curb or can require extra attention. So to your point about being aware of possible visual restrictions from
Well,
glaucoma.
absolutely. And so the other thing to be cognizant of, because as we know, loss of vision happens very slowly with glaucoma for almost all patients. And because it's so slow, most people are unaware of the disability or don't really notice it until it's quite severe. But there is a disability, and you need to make adaptations. And so the adaptations, like a rainy day, a low contrast day, is very hard on people with glaucoma. So being more cautious, not driving on those days. Very bright days can be very hard because they can bleach the retina. Wearing a visor, wearing something that helps reduce glare can be greatly beneficial. How you light your home can help prevent injury. There has been good research showing, Priti Brahmalu, with whom I've worked over the years at Wilmer, has published a lot on this and shown that people with glaucoma do not adequately illuminate their houses. So that's another very beneficial thing to do.
So that does also bring up the whole idea of low vision assistance. And there are, in fact, low vision specialists, and I assume you probably refer patients to low vision specialists as well, who can deal with a lot of these aspects of succeeding at daily living with glaucoma. Any comments
Absolutely.
on
And in
that?
fact, it's funny you bring that up. I just got a message through the electronic medical record this morning from a patient of mine who has relatively severe visual field loss, who said, "Thank you so much for referring me to this doctor. It's really made a huge change in how I perceive my ability to use my vision." So that was really like rewarding. And I think we underutilize those folks, and people who are suffering from disability should definitely seek them out.
Now, you did show a picture of the eye care home tonometer, and I found your discussion of how the administration of care, or how the office procedures will have to change just because of the simple volumes of patients and the insufficiency of the number of ophthalmologists. But what about home tonometry today? I'm under the impression that it is being used in some cases to help actually diagnose pressure changes that might occur at night, or to give more readings. Because again, you talked about perimetry and you measure once a year. And with tonometry, you measure maybe at the same time every day, and again, only a few times a year.
Yep.
What do you think about home tonometry being more widely?
Yeah, I mean, I think that, the problem right now is there's no, like I said, business model, except that you have to buy the device or rent the device, and there are companies online that will let you rent or buy it from them. The cost is in the order of $4,000 to get a home tonometer, and then there's the disposable tips, which you have to keep paying for. So it's not trivial for the average patient. The average person, that's a pretty big expense. And so we have to think, do we really need it on everybody? In my practice, I mainly use it when somebody seems to be getting worse and I don't know why. Their pressures always seem fine. So that's an ideal person to maybe get evening measures. Some people do spike quite a bit in the evening, and that could alter your decision-making, maybe lead to surgery that you might not have considered. But for the average patient, I think it's a tough call. It has to do with how much resource you have. There are certain subsets of patients where I think it can be quite helpful. There are conditions like pseudoexfoliation where the pressure can go up quietly but quite high. And if you have that and could detect that earlier, you might prevent vision loss. And so in those instances, if you can afford it, it might be a beneficial thing to have.
Now, you didn't mention SLT at all. So I'm just curious, in sort of this new paradigm of more remote testing, fewer doctor visits, home monitoring, and so forth, how does SLT potentially impact that now that it has, the preferred practice patterns are now suggesting that should be the first treatment for a newly diagnosed primary open-angle glaucoma patient?
Yeah, so in my practice, it is the first recommended treatment for almost all newly diagnosed patients. It is, based on clinical trials. People who get that as their initial treatment do somewhat better than people who start with medications. and it's safe and effective. And so for that reason, I think it should be more widespread. We can in fact facilitate that so it could be easier, because now every office has to buy the device. There is a recently FDA approved device that does not involve the physician putting a lens on the eye, but can just do the procedure somewhat automated, which may make it easier to do it in a less centralized way. I have no experience with that device, so I can't really speak to it, and I haven't really seen much in the way of publications. But certainly, I think newly diagnosed glaucoma patients should be thinking about or seriously considering laser trabeculoplasty as their first-line therapy.
So another question, why is it that there's sort of a constant changing of medications? It seems like medications don't continue to work as well as they may have. Is that common? A lot of people, or I shouldn't say, but I think many people are on more than one eye drop to get the optimal pressures. And there's often changing in drops. Could you comment on that?
Well, the main reason we change therapies is either the therapy didn't work well enough, or it caused some adverse effect that was intolerable. Certain of our medications are highly likely to cause allergy, and so those often have to be stopped. Other medications just may not be working well enough, and so patients often end up on more than one drop. Another argument for starting with laser trabeculoplasty, because people who get laser first require fewer medicines. Another big trend in Europe is towards preservative-free medications. In the United States, it's a little harder because they tend to be much more expensive for patients, or there's a lot more involved in getting them. But we do recognize more and more that the ocular surface at the cornea, the conjunctiva, is irritated by the preservatives, and trying to be preservative-free may be beneficial to really your overall vision, because if your cornea is irritated, you may not see as well.
I guess another question was on minimally invasive glaucoma surgery. And is that something you could maybe comment on briefly?
Yeah, sure. So I was saying that, eye pressure lowering is kind of where it is, and I think there'll be variations on the current theme. So the current theme is we can do very lesser procedures that let more fluid out the normal pathway, and those are often referred to as minimally invasive glaucoma surgeries. And there's a lot of ways to do that, so there's been a lot of innovation, but the evidence base for which one is best and which should be done when is quite limited. And so you're really now more on my own approach, like this is how I do it, as opposed to there was a big clinical trial that showed this is better than that. But those procedures tend to lower pressure less than the bigger procedures. And so right now we have those, and then we have the bigger procedures. And there are, again, lots of innovations going on around the bigger procedures. And so there may be better mousetraps, but I don't see anything revolutionary today that's going to suddenly give us pressures of 10 and everybody with no complications, which is what we all want, right? If we could get 10 with no complications, I'd have that surgery, right? That's the kind of surgery we want to do. And none of what's been going on recently will give us that.
Well, and as you talked earlier, maybe that's a place for neuroprotection where you're less concerned what the pressure is if you can really make those neurons and axons resistant somehow, or make them happier.
Absolutely, and maybe the combination of the two is what does it. So you get the pressure below 14, let's say, and you've got a neuroprotectant, and everybody's fine.
Yeah.
And so
I'm ready for it.
Me too. Can't wait.
Well, thank you for a wonderful presentation and for answering all these questions, and certainly for your really unwavering commitment to helping people affected by glaucoma. Glaucoma Research Foundation is committed to finding innovative solutions, funding groundbreaking studies, and supporting initiatives that bring us closer to a future free of glaucoma. We know that it is only through continuous investment in research that we can unlock new treatments and ultimately a cure. We're profoundly grateful to our generous donors who share and believe in our mission. Their ongoing support not only fuels critical research, but also powers our patient education programs, which provide essential information and resources to those affected by glaucoma. This partnership between our dedicated researchers and our incredible supporters is the cornerstone of our progress. Every gift, regardless of its size, has a significant impact. Together, we are one step closer to a world free from glaucoma. Thank you for being a vital part of this journey, and see you next time.